simple fact is I'm 64 years old, and I was born in Adelaide, and I've stayed in Adelaide. In fact, I've never moved more than 4 kilometres from my place of birth. So that's been a very risk taker. So that's a different perspective on my curriculum vitae. My talk, I hope if you find it boring, at least there'll be some cartoons in it, so you'll have some relief throughout. And the first cartoon, it was your idea to experiment more in bed and you haven't even touched your frog. And the point is, I'm really passionate about the concept of the academic teaching hospital, where clinical care, teaching and research are closely integrated and viewed as one. And then the second concept is the fundamental importance of research to good quality clinical care. So in fact, I believe that research is the greatest safeguard for clinical care. The concept that the stomach is central to diabetes, I'll make sure there's enough time for questions afterwards, and I've said that anyone can have my email address, just don't send abusive messages, that's all I ask. It's not new. Areteus of Cappadocia was a follower of Hippocrates, and he suggested in AD 80 that in the broader sense diabetes should be regarded as a disorder of the stomach. And I have been conducting research in this area for 35 years or so, a very long time. Many people suggest that was an inappropriate career choice, but nevertheless that's what I've done. And the exciting thing about clinical research, as you'll hear from Christina next, is it leads to a redefinition of previous concepts, previous beliefs. So I'm going to tell you a story relating to these areas in the next 30 minutes or so. Firstly, how common delayed gastric emptying is in diabetes. The synonymous word is gastroparesis, the stomach emptying more slowly than normal. The importance of symptoms, nausea, vomiting, fullness after meals, how common that is in people with diabetes and why it's important. How do we treat people who have those symptoms and have delayed gastric emptying? You'll find that none of this is unusual, rare. And then probably more importantly, what does the rate of stomach do to blood glucose control? And that ties into a number of the people here will be on drugs such as Byetta or Bydureon or other ones, and these are all related to the hormone glucagon-like peptide 1. And it's what do these drugs do to gastric emptying. So there's been a marked translation of observations and a number of new ideas in the last 30 or so years. So I'm going to talk, I'm trying to achieve a lot, and I hope you don't find it too boring, and if you do find it boring, please don't communicate that to me. So it was Mark Twain who suggested to eat is human, to digest divine. So how the stomach works is complex. So we'll start by how the stomach works. So many of you know that the heart is a so-called pacemaker, something that determines the rate at which the heart beats, normally 70 beats a minute or so. Well, the stomach also has a pacemaker situated at the top of the stomach. That's the esophagus or gullet, and that's the beginning of the small intestine, and that's called the pylorus, just where the stomach ends. So at the top of the stomach here is a so-called pacemaker region, but it's not 70 per minute, it's about 3 per minute, it's a much slower pacemaker. And this determines the frequency of contractions. And then what the stomach does is grind solid food, solids that can be ground down, into very, very small particles. So solid food is usually less than 1 millimetre in size, so essentially liquefied, before it empties from the stomach. And the rate at which food empties from the stomach into the small intestine is normally tightly regulated. So it grinds food into very small particles. So because of this grinding process, there are major differences in patterns of emptying of solids and liquids. So for solids, there's an initial grinding period of about 20 or 30 minutes, and then the solids empty from the stomach in an overall linear pattern, a continuous linear pattern. If you have something like water or dilute glucose, it empties much more rapidly without any so-called lag period and follows a sort of mono-exponential pattern. It's certainly not linear. And then if you actually increase the amount of nutrients in a liquid, it doesn't have a lag phase, but empties in about a linear fashion. So this is when if someone's hypoglycemic, it's highly relevant what you consume to restore the normal glucose. So there are fundamental differences in patterns of solids, non-nutrient liquids, and nutrient liquids. And the overall pattern of emptying is dependent on contractions in different regions of the stomach. I don't need to go into that, but the message is the rate at which the stomach empties is really not controlled by the stomach, but by what comes out of the stomach. Feedback arising from the interaction of nutrients with the small intestine. Okay? Are you all awake? Please say if you're still awake. So that's how the stomach works. How do you measure the rate the stomach empties? So this is an apocryphal story. So what you could do before ethics committees. So the Holy Roman Emperor Frederick II ordered 2 men to be fed a large meal and then sent one hunting and ordered the other to rest to determine under which condition digestion is aided. Frederick had both men executed and disemboweled to discover that the stomach of the man who was rested was empty, while that of the man who had been hunting was full. And I have this to say we're no longer allowed to do that sort of experiment. So the next experiments were done on people who had a so-called gastric fistula. That means there's an opening between the stomach and the outside. So I'll just show you a couple of examples of this. So Alexis St. Martin, this is in 1833, was meant to be a highly unpleasant individual, and as a result of a gunshot wound, there was an outlet between his stomach and the surface. So he was studied by this chap Beaumont, and a number of experiments were performed on Alexis St. Martin, who was highly unreliable, and Beaumont wrote a book about Alexis St. Martin's stomach. So the experiments were done for many years. So his fistula was as a result of a gunshot wound, and probably the most famous one is Tom. I don't know what Tom's last name was, but Tom drank very, very, very hot clam chowder. And so he got a stricture in his gullet, and the only way he could be fed at that time was to make a fistula, to put food directly into the stomach. And he was studied over a period of 70 years. It was eventually the first investigator was Dr. Wolfe, and his partner was also called Dr. Wolfe with 2 Fs, and they studied Tom for 17 years, really a series of anecdotal observations only interrupted by Tom's death. So that's what you could do with science. Now, so what is Professor Horowitz's controversial technique of simultaneously confronting the fear of heights, snakes, and the dark? So there has been dramatic change in techniques, and there are now a number of techniques which can be used to quantify the rate of gastric emptying in people without killing them. So, and the most common of these is scintigraphy. And scintigraphy means a sort of scan. So some of you will have had a lung scan, a liver scan. You use a very small dose of radioactivity, certainly not one that is dangerous, and you put that small amount of radioactivity in a meal. And you can quantify, so this is the shape of the stomach divided into two, and you can quantify the disappearance of that meal from the stomach. So a person just has to, probably some of you will have participated in our research studies, all you have to do is eat a relatively palatable meal and sit in front of a camera reading a newspaper or whatever you choose to do. So it's non-invasive. So we suddenly, in the early 70s, had a non-invasive technique. So then we could really look at what happened to gastric emptying in diabetes. Now, in 1958, there was a classical paper by someone called Cassander from the US, and he described abnormal retention of barium. Barium is a very non-physiological marker in 6 people with diabetes. And this is the sort of picture he's got. So this is a barium-filled stomach. It's a picture taken at about 4 hours. There should be no barium in the stomach at that time. And you can see there is a small amount down here. The laser's not working that well, in the small intestine. So gross retention of barium, and there were no symptoms whatsoever. And 5 of these 6 people had type 1 diabetes, 1 had type 2 diabetes. He called this gastroparesis diabeticorum. And he suggested it may be much more common than was recognised, and they didn't have any good treatments for it at that time, and it could influence the management of diabetes, and he was correct. That's 1958. So we then applied those techniques to outpatients, community patients, people with diabetes, and this sort of picture, so the normal range of gastric emptying is in the light blue. So you have solids and liquids, and in this patient, gastric emptying of solids is markedly delayed, and gastric emptying of liquid is markedly delayed. So the curves are quite outside the normal range. Can people see that? I don't? Okay. And you can see in the retention of the stomach, the amount of solid food in the stomach at 100 minutes. So this is a group of about 90 people with both type 1 and type 2 diabetes. So what I want to show you, I won't show you the laser. This is the pink area, that's the normal range. And we're comparing to, these are so-called healthy subjects we've scanned. And we've looked at solid emptying and we've looked at liquid emptying. So what are the messages from this? Firstly, the normal range of gastric emptying is very wide. There's a 3 or 4 times variation. Secondly, many of these people with diabetes have delayed gastric emptying, about 40%. For a lot of them, it's just above the normal range, but suddenly gastroparesis has become common instead of rare, occurring in about 40% of people. And a few people have actually more rapid gastric emptying. Did everyone see those 3 messages? Okay. So delayed gastric emptying suddenly in about 1985 became common. So gastroparesis occurs frequently in long-standing diabetes, whether it's type 1 or type 2. So is that surprising? Struck from behind or right, and from my first examination of the wound, I'd say this was done by some kind of heavy blunt object. If it's not surprising, because you had the same population, what is the prevalence of eye damage? What is the prevalence of kidney damage? What is the prevalence of peripheral nerve damage? It's all about 40 or 50%. So it wasn't really a surprise, just that people had not looked. So we've got a common problem. What are the causes of it? Well, the answer is, I've got a list here, but it can be damage of the nerves in the gut itself or supplying the gut. But what is probably of most importance is if we make the blood glucose level about 15, and we measure gastric emptying, and we compare that to gastric emptying when the blood glucose is about 6, the rate of stomach emptying is much slower when the blood glucose is higher. So a number of abnormalities, including elevated blood glucose, contribute to delayed gastric emptying. So we come to symptoms. Now, I start with this because the parallels are with erectile dysfunction in diabetes. It was thought to be an unusual problem until doctors decided to ask people. And then it became a very common problem. So more than 50% of males with diabetes have erectile dysfunction. It's a fact, and it's also good you can do something about it. So when you ask people about symptoms in diabetes, you find these are just so-called upper gastrointestinal symptoms: appetite, fullness, nausea, vomiting. They're much more common than in people who don't have diabetes. And many of these people will often not volunteer symptoms such as nausea or vomiting. They will certainly not volunteer symptoms such as fecal incontinence. But it's common, and you can do something about it. So doctors need to ask, and people need to be more common. So if you do have symptoms, you're more anxious and you're more depressed. So they really affect quality of life adversely. Of course, we can't say what starts first. Did the depression cause the symptoms or the symptoms cause the depression? But they're a major factor on quality of life. Then we were surprised. So if I show you this graph, we've got our people and we've measured their gastric emptying. So this is our normal range, okay? So 40% or so outside the normal range. And then we've asked them about symptoms. And you get a relationship which is statistically significant, but it's relatively weak. So symptoms are not predicted closely by the rate of gastric emptying. So then you could say, what do doctors do? They say, it's probably psychosomatic, but keep taking the weed killer. You know, it's your problem, the patient is mad, it's their problem. The fact is we don't really understand this problem, is the message. Not that people always search for an explanation, and if there's not an explanation, it's the patient's problem, which is of course wrong. So symptoms occur very frequently. Many of you will have symptoms. In the community without diabetes, symptoms are really common, and it's very strange because symptoms get better and they get worse. And if you look in the community, the percentage of people whose symptoms get worse is matched by the number of people whose symptoms get better, so the prevalence is relatively constant. But they affect quality of life adversely, and we don't really understand them. So the association of symptoms such as vomiting with the rate of gastric emptying is relatively weak. Next part is, how do we manage people with symptoms and delay gastric emptying? It's common. So we know that if long-standing diabetes, the prevalence is about 40%. Well, the message is you try and optimize blood glucose control, because high blood glucose levels slow gastric emptying. I mean, anyone who wants some of these slides can have the slides if they want. You may modify dietary habits, lower fat meals, but that has not actually been shown to work. And the mainstay of treatment, which is far less than optimal, is the use of drugs which make the stomach empty more rapidly. And they're called prokinetic drugs. Now, there are other things being explored which I thought you may be interested in. One is the equivalent really of giving TENS, nerve stimulation, to the stomach. So you have a very high frequency electrical stimulation and a device which has been shown to marginally reduce the risk of symptoms. It's available to some extent in Australia. I don't want you to think it's wonderful, because it's not. But it's a new avenue. The other thing you'll be aware of, if humans are willing to inject botulinum toxin into anything, basically. And the pylorus is the outlet of the stomach, and the concept is that the pylorus is contracting too much. That's why the stomach emptying is abnormally slow. And so there's studies going on where if you paralyze the pylorus, does that improve symptoms? It certainly has not yet been shown to work. So we don't have very good treatments for symptoms which unquestionably occur very commonly and unquestionably affect quality of life adversely. So currently prokinetic drugs which make the stomach empty more rapidly, are the mainstay of treatment. Is everyone still awake? You look quite alert. It's very good. So the final component you'll be relieved is, what does gastric emptying do to blood glucose control? We come back to Arrhetius and we come to what Cassander said, that it could influence blood glucose control. And this is an area where there have been major developments. Now remember, I showed you that the range of gastric emptying in people without diabetes is very wide. There's a large variation, about 3 or 4 times variation. So this is the converse. So I've showed you how high blood glucose levels slow gastric emptying, and this is what gastric emptying does to blood glucose. So a very, very important message. Monnier is a Frenchman. In fact, he's a mathematician from Montpellier. But most people in Western societies, whether people have diabetes or don't have diabetes, eat 3 larger meals a day. And most people will also have snacks. Now, because nutrients empty from the stomach without it being delayed at somewhere between 1 and 4 kilocalories per minute, 1 and 4 kilocalories per minute, you can see that humans are predominantly in the postprandial state. So if anyone tells you measure your fasting blood glucose, well, they should, that is only the one just before breakfast. All the others have food in the stomach or intestine, unless someone has unusual dietary habits. So there's increased recognition that postprandial blood glucose is very important to overall glycaemic control, usually measured by hemoglobin A1C, which I presume half the room has measured regularly. So you have to treat postprandial blood glucose, and unless you minimise the rise in blood glucose after a meal, you can't achieve ideal blood glucose control. So there should generally be much more emphasis on postprandial blood glucose measurements. It depends, of course, on the individual circumstance, but what happens before a meal and what happens about 2 hours after a meal. So Cassander, who coined that descriptive term, and he was referring to people treated with insulin, said the retention of stomach contents in a diabetic obviously may cause confusion as far as food intake and utilisation are concerned. So it could be a problem for blood glucose control. And it's now recognised that the stomach is central to blood glucose control. So it regulates the delivery of nutrients to the small intestine. It influences how much food people eat. And then when you add insulin to this, you've got additional complexity, because fundamentally, if you give someone insulin, it doesn't matter if gastric emptying is slow, it doesn't matter if fast, it doesn't matter if it's normal, but it needs to be predictable. Because it's only if it's predictable can you coordinate giving the amount of insulin to match the amount of nutrient absorption. So it's, for people on insulin, whether type 1 or type 2, it's all about coordinating the two. And that has not really reached practice at this stage, but will. So these are people with type 2 diabetes on metformin alone, and it shows a very important message. So they've had a 75-gram glucose load, the oral glucose tolerance test. and we've measured the amount of glucose emptied from the stomach. So if there's more here, more empty goes up here. And we've looked at their blood glucose response there. So if their rate of emptying is relatively faster, the rise in blood glucose after that meal is much greater. So I know there's statistics and dots, but I hope everyone can see that. So if the amount emptied at 60 minutes is more, the blood glucose is higher. And this is without any treatment or any intervention. This again looks complicated, but it's not complicated. I'll just show an example. It's not done by us. So this is a type 2 population, type 2 patients. If they slow gastric emptying, in this case giving a small dose of morphine, what you do is completely flatten the blood glucose profile compared to not having the slowing. If you accelerate it, in fact the antibiotic erythromycin accelerates gastric emptying, blood glucose levels are much higher. Now they're US units, so you've got to divide by 18, but this is the difference between 200 and 300 approximately, so it's a difference of about 6 millimoles per litre. So you can have a profound influence on the blood glucose response to a meal by modulating gastric emptying. Is that seen by people who need to? Okay. So, is that predictable? Well, it is predictable because we go back to alcohol. And alcohol, like glucose, is absorbed predominantly from the small intestine. And this is research that we did years ago. It's the same thing. You have an alcohol-containing drink, and it can be after a solid meal by itself or 90 minutes later, but if your alcohol empties from the stomach more rapidly, you get a much greater alcohol response, peak alcohol response. So the question here is whether you want to get drunk earlier or later. But if anyone wants to talk to me about breathalyzers, they can write to me. It's got a lot of implications. So something that's absorbed from the small intestine, whether it's glucose or alcohol, is dependent on the rate of gastric emptying. And it's dependent on the rate of gastric emptying because there's this wide variation in people who don't have diabetes, and the variation is even wider in people who do have diabetes. So some studies have been done which have really proved the obvious. So one from Japan, and they had some healthy patients with type 1 diabetes, and 6 of them, and 5 of them had markedly delayed gastric emptying, gastroparesis. And they're all on insulin. And they looked at how much insulin was required to keep the blood glucose in the normal range for the first 2 hours after the meal. And the people with gastroparesis initially needed less insulin, first 2 hours. But then between 3 and 4 hours, they needed more insulin because the food was going to absorb. So it shows how gastroparesis in people who are taking insulin, whether type 1 or type 2, is a critical determinant of how much insulin is required to achieve good blood glucose control. So we have the concept, which is a very recent one, of modulating gastric emptying to improve blood glucose control. And that's to reduce the risk of high blood glucose and possibly even more importantly, minimize the risk of hypoglycemia, low blood glucose. So if you have type 1 or insulin treated, the principle is to coordinate gastric emptying with the delivery of insulin. Doesn't matter if it's fast, slow, or normal, it needs to be coordinated, needs to be predictable. That means I need to stop. No, I don't. But if you have type 2 diabetes and you're not on insulin, the slower gastric emptying is, as long as you don't feel sick, the better. Completely different. Now, this is a long list of drugs. Don't worry about drugs, but they're so-called agonists of GLP-1, glucagon-like peptide 1. And they're given currently subcutaneously, and I'm sure people in the audience will be taking exenatide, which is given twice a day, Bydureon, which is given once a week. They're the only two which were on the PBS until the recent advent of one called Trulicity dulaglutide, they sometimes say, and some of you may be on liraglutide. So this is a widely used drug class in type 2 diabetes with advantages over insulin is it causes weight loss rather than weight gain, and it doesn't cause hypoglycemia by itself. So they're a very widely used class of drugs. The first of these drugs, you probably recall, were exenatide, came in, I think, 2005, and in fact comes from the venom of the Gila monster lizard. That's another story. But the point is, if you look at a drug like exenatide, this is again one of our studies, and the blue area is when you have a placebo injection, and the other colours are the red and the yellow are in exenatide. You can see that exenatide has a profound effect to slow gastric emptying. And that's how it reduces the blood glucose response to a meal. It may cause nausea, but usually not, and this is not due to nausea. So we've got a class of drugs which is used very widely, which acts by slowing stomach emptying for type 2 diabetes. And more importantly, there's a logic for the use of these drugs in combination with so-called basal insulin like glargine, for example, or Lantus. Because the basal insulin is very good at blood glucose levels before a meal, but it's not very good at preventing the rise with a meal. And if you have a choice of a short-acting insulin with the risk of hypoglycemia, or a drug that will reduce the rise after a meal without causing hypoglycemia, I know what I'll choose. So this is very used increasingly in combination, and they've now developed fixed dose combinations, not yet freely available in Australia, where you have both a basal insulin and a GLP-1 agonist, which you inject at the same time. So you're looking at both fasting and after a meal, and it's by slowing gastric emptying. So that's sort of the end, and this is Lassie get help, so she's gone to the psychiatrist, and I'm happy to ask questions. I think we'll have enough time. So what are the points? So you can say I've spent 35 years and it's been a waste of time, but don't tell me that. So firstly, symptoms, gastrointestinal symptoms are very common in the community at large, but more common in people with diabetes, whether it's type 1 or type 2. That's not widely recognised. Also, delayed stomach emptying, gastroparesis, occurs very frequently. Perhaps 40%, maybe the prevalence is getting less as blood glucose control improves. The rate of stomach emptying is slower when the blood glucose is high, and possibly most important, because it's not really widely appreciated, that the rate the stomach empties is a major determinant of the blood glucose response to a meal. And didn't talk about diet today, I'm happy to answer questions, but certainly this has now been translated to a specific drug treatment which is widely used, which reduces the rise in blood glucose after a meal, predominantly by slowing gastric emptying. So when you think about research, Christina's talking next, research is mainly about failure. You hear about successes, but you expect to fail on a daily basis. And so I always look at this quote, it's called Alice in Wonderland, and it's a conversation with Alice and the Cheshire Cat. I said, would you tell me please which way I ought to go from here? That depends a good deal on where you want to get to, said the cat. I don't mind much care where, said Alice, then it doesn't matter which way you go, said the cat. So long as I get somewhere, Alice added as an explanation. Are you sure to do that, said the cat, if you only walk long enough. So it's a real summary, but you're probably sitting there feeling confused, and this is my last slide. I've used it for years because, of course, on that side, you have type 2 patients who are overweight. On that side, you have scrawny, poorly controlled type 1 patients, and they've just heard that the stomach is the most important organ in diabetes, but they're really not quite sure what to do with that information. So thank you very much for your attention. I hope it hasn't been too boring.